الله الرحمن الرحيم. أحبتي الكرام، السلام عليكم ورحمة الله وبركاته. يسرنا حضوركم لافتتاح المؤتمر العراقي الطبي في دبي في دولة الإمارات العربية المتحدة لهذا العام، ويسرنا أن نفتتح هذا المؤتمر بالنشيد الوطني لدولة الإمارات العربية المتحدة وجمهورية العراق يتلوها آيات من القرآن الكريم.
بسم الله الرحمن الرحيم. الرحمن علم القرآن خلق الإنسان علمه البيان. الشمس والقمر بحسبان والنجم والشجر يسجدان. والسماء رفعها ووضع الميزان.
Ladies and gentlemen, may I introduce myself. I'm Dr. Manaf al-Hashimi, member of the Scientific Committee of the Conference and Consultant Urology in Mujib Hospital of Abu Dhabi. And it's my pleasure to announce the opening of the Iraq Medical Conference under the esteemed patronage of His Excellency Sheikh Nahyan Mubarak al-Nahyan, the Minister of Tolerance and Coexistence and the United Arab Emirates. It's our great honor to welcome all of you to the Iraq Medical Conference taking place this year in the vibrant city of Dubai and hosted by the Library of Hamad ibn Rashid. The architecture stunning and the venue that perfectly complement the events of significance and prestige. This year the conference is held under the theme Advancing Medical Genomics and Genetics, Bridging the Medicine and Future Science. This event reflects the vision of the United Arab Emirates to provide the cutting-edge resources, foster collaboration, enhance the quality of medical care in our region. By addressing the critical advances in medicine, we aim to pave the way for integrating future science into today's medical practices, creating a lasting legacy of excellency and innovation. We are also delighted to announce the inclusion of prestigious Bow Award ceremony that will be held tomorrow morning. The Bow Award, named after the ancient Mesopotamian goddess symbolizing medical care and healing, honors pioneers in medicine whose contribution have profoundly impacted the field. The Iraqi pioneers have shaped medicine since ancient Mesopotamia through the Islamic Golden Age to modern advancement, contributing globally despite challenges and continuing to inspire the innovation in healthcare. Ladies and gentlemen, this conference is the culmination of months of preparation and tireless effort of many dedicated teams, including the organizing committee, the scientific committee, and the Bow Awarding committee. Their unwavering commitment has instrumental in bringing this vision to life. The scientific committee served as a cornerstone of our event, fostering connection with esteemed speaker and ensuring the deployments of an exceptional scientific program. We are privileged to welcome many distinguished pioneers in medicine whose contributions have enriched this schedule and elevated to a level that we are truly proud of. The Bow Awarding Committee and the Board of Trustees also have several meetings to select most of deserving candidates through many years. And now it's my great pleasure to invite the esteemed head of the scientific committee, Dr. Yahya Kiwan, to share with us his insight that made the conference, along with the speakers and moderator, a successful event. Dr. Yahya Kiwan.
Very emotional actually, but I have to be very strong. السلام عليكم، بسم الله الرحمن الرحيم. معالي شيخنا حيان بن مبارك آل نحيان، وزير التسامح والتعايش المحترم. أعزائي الزملاء والضيوف الكرام، أرحب بكم جميعا في هذا المؤتمر الطبي الذي يجمعنا اليوم لنتبادل المعرفة والخبرات في مجالنا الطبي. نحن هنا لنتعلم من بعضنا البعض ونتعاون في مواجهة التحديات الصحية التي تواجه مجتمعنا. إن هذا اللقاء هو فرصة رائعة للتواصل مع الزملاء المختصين والاطلاع على أحدث الأبحاث والتطورات في هذا المجال. I have to switch to some English because I will have to mention some of the housekeeping points which are very important, I believe. I have some points to remind dear speakers. Please and kindly cover your presentation over 12 minutes and to allow for 3 minutes for moderator to introduce you. For my colleague moderators, kindly stick to the guidelines which we sent to you. We shared with you, and your role is very important to collaborate between the speakers and the audience in order to manage the time allocated for everybody. Please attend the workshop, and one of the two important workshops today is the genetic workshop and the regenerative medicine workshop. We really selected distinguished speakers for the two workshops. أتمنى لكم مؤتمراً ناجحاً ومفيداً، وشكراً إلى جميع الذين ساهموا في التحضير والإعداد، وخاصة إخواني من أعضاء اللجنة العلمية، وشكراً جزيلاً.
Ladies and gentlemen, again for the bow and the bow award tomorrow, it will commence with the official bow awarding ceremony that from 9 to 11 morning. And as I said, bow awarding belong to one of the important roots in the Mesopotamian culture, and it reflects the root of care at that time. From that one, the bow awarding committee started, and the board of trustees started to have several meetings to select the most deserving candidate for this prestigious award. And all of us know that Iraq is a home to numerous pioneers in the field of medicine, whose groundbreaking achievements have significantly contributed to healthcare advancement both regionally and globally. It's my great pleasure to represent the head of the bow awarding committee, the pharmacist Dr. Imad Jawad, to share his insights about the bow awarding committee.
سيداتي سادتي، جائزة باو تكريم الإبداع والقيادة في القطاع الطبي والصحي في العراق. الآلهة باو رمز العطاء والرعاية. تعتبر الآلهة باو في الميثولوجيا السومرية من أبرز الآلهة في تاريخ حضارة وادي الرافدين، وهي تجسد للشفاء والرحمة والرعاية الصحية. كان يعتقد أن باو تحمي المرضى وتشفيهم، وكانت تكرم كرمز للخير والعطاء الإنساني. ارتبط اسمها بالطب والصحة في مجتمعات الرافدين القديمة، مما يجعلها رمزاً ملهماً لأي جائزة تحتفي بالمساهمات في هذا القطاع. أهمية جائزة باو من لسانه وعلى نهجه في احتضان العلماء والكفاءات وتكريمهم. المغفور له الشيخ زايد بن سلطان آل نهيان، وبرعاية معالي الشيخ نهيان بن مبارك آل نهيان وزير التسامح والتعايش، الرئيس الأعلى لجمعية الإمارات للأمراض الجينية، وبإشراف وقيادة الدكتورة مريم مطر، مؤسسة ورئيسة مركز الشيخ زايد للأبحاث الجينية. وانطلاقاً من رمزية باو، جاءت جائزة باو كإحدى أهم الجوائز التي تمنح للقيادات والمبدعين في القطاع الطبي والصحي في العراق. تهدف الجائزة إلى تسليط الضوء على الأفراد والمؤسسات الذين أبدعوا وأسهموا في تطوير الرعاية الصحية، سواء من خلال الابتكارات الطبية أو تحسين الخدمات الصحية أو المبادرات المجتمعية التي تعزز صحة الأفراد. والجوائز هي جائزة الإنجاز مدى الحياة بالطب، جائزة التميز الطبي للأطباء، جائزة التميز الطبي للصيادلة، جائزة التميز الطبي لأطباء الأسنان، جائزة التميز بالبحث والاختراع الطبي، وأخيراً جائزة التميز للدعم الطبي للمجتمعات. تمثل الجائزة اعترافاً رسمياً بالجهود التي تبذلها الكفاءات العراقية في ظل التحديات الكبيرة التي يواجهها القطاع الصحي، كما تسعى إلى تحفيز المزيد من الإبداع والابتكار وتعزيز روح القيادة والتفاني بين العاملين في المجال الطبي. شكراً لكم جميعاً.
وبرعاية معالي الشيخ نهيان بن مبارك آل نهيان وزير التسامح والتعايش والرئيس الأعلى لجمعية الإمارات للأمراض الجينية، بدعم من هيئة دبي للاقتصاد والسياحة ومؤسسة الإمارات للخدمات الصحية التابعة لوزارة الصحة، وفريق شكراً لعطائك والراعي البلاتيني فارمالاب وAMS. تستضيف دبي جائزة باو والمؤتمر الطبي العراقي في اليومين 24 و25 من شهر كانون الثاني يناير عام 2025، والذي يعقد في مكتبة الشيخ محمد بن راشد آل مكتوم. تماشياً مع توجيهات القيادة الرشيدة لاحتضان العلماء والمتميزين من بلاد العالم، والتي تعكس الرؤية التي أرساها المغفور له الشيخ زايد بن سلطان آل نهيان طيب الله ثراه للاحتفاء وتكريم الكفاءات العربية التي ساهمت في خدمة الإنسانية. خصصت الجائزة في دوراتها الأولى لتكريم أبناء الرافدين من الكفاءات والمبدعين من حول العالم. من المكرمين في هذه الدورة الدكتور علي الحرجان استشاري الطب النفسي الذي أرسى النسخة الأولى من هذا التجمع العلمي، وسيتم تخصيص كل دورة من الجائزة للاحتفاء بالكفاءات من دول عربية مختلفة.
دكتور صالح العمري please to the stage. أستاذ الدكتور مكي حمادي فياض، الدكتورة ابتهال فاضل، الأستاذ الدكتور مؤمن الريفي please. الدكتور علي السرحان،
a university professor in molecular virology and genetics. It is my pleasure to welcome you all also to the second edition of the Iraqi Medical Conference. I will be your moderator for the first session of the day, discussing the landscape of genetic diseases. It will be my pleasure to introduce the distinguished speakers of the program, who are all sitting right in front of us on the stage now. For your information, we will have a series of 50-minute presentations, and at the end of the talks, we will have a questions and answer session, where you will have the opportunity to ask questions to our panelists and speakers. So please take advantage of this opportunity and find out more. In this first session, we are very pleased to welcome our keynote speaker and our special guest, Dr. Makki Fayyad. Dr. Makki Fayyad is a very special guest from Abu Dhabi. Dr. Makki Fayyad is a senior consultant in Health Shield Medical Center in Abu Dhabi. Dr. Fayyad is a consultant gastroenterologist and hepatology, a fellow of the Royal College of Physicians London, and a fellow of the Royal College of Physicians in Edinburgh. He will be sharing with us his insights on closing the gaps, strategies to avoid missing the diagnosis of multi-system and critical cases. With that, I ask you all to give Dr. Fayyad your full attention and help me in welcoming him to the stage. Dr. Fayyad, please.
شكرا دولة الإمارات التي تحتضن كل المؤتمرات العلمية. حقيقة talk very quick because you have for the sake of time. هذه بلاد الرافدين. Slides. It's not coming. Okay. حقيقة talk مالتي راح يصير على health fragmentation of the healthcare system. Solution lies in integrated approach to care. Medical science has done a lot good. Diseases that were incurable, we can fight. The average life expectancy increased. However, there's a downside in the medical practice. Medical science has also stimulated far-reaching specialization, leading to a reductionist, disease-specific approach. I think this is a very nice slide. It doesn't matter how many resources you have if you don't know how to use them. That's what you are in Iraq now. And it's actually, you only see what you look for. شوف الرسم هذا. وراسم واحد شباك نفسه والناسي الشجر وراه. Missed diseases in the UAE. Colorectal cancer affecting the young population here. How many of you above 40? No one. The risk of cancer above 40 is 5% on all of you. So please check yourself. We see cancer 15 years younger than America. Celiac disease is underdiagnosed at the Emirate. We did the studies. Celiac affects 1 to 2% of the population here. Hyperelasticity syndrome is quite common. Nobody diagnosed it. I'll come to it. Cowden disease, familial genetic disease with multiple cancers, familial tylosis, angioedema of the bowel. And there's a new disease, which is IgG4-related disease. If you have not heard about it, listen about today. This can affect the liver, causing cholecystitis, pachymeningitis in the brain, pancreatitis, and hypophysitis. And documented diseases here in this country, we have seen celiac with epilepsy, celiac with infertility, celiac with nephritis, celiac with dermatitis herpetiformis and eczema. IgG-related disease, you have seen it as pancreatic cancer, and sarcoidosis, lac reaction with colon polyps. Cowden disease missed by 7 centers in the world, diagnosed here. Brain tumors treated as reflux disease by colleagues. Superior intercardial syndrome with elasticity in 25 cases, all missed as psychiatric cases. Mesenteric paniculitis in 20 cases, all missed, by the way. Periodic disease like Mediterranean fever, hyper-IgD. Herpes zoster, most of the time missed because nobody examined. Familial tylosis and esophageal colon cancer. We have now new entities, microscopic colitis, amyloidosis, manganese poisoning, stimulating Parkinsonism, solitary rectal ulcer, very common, by the way. Straining and defecation with constipation, with ulceration. Behçet disease with negative HLA-B51. Tuberculosis and Crohn's disease, a very challenging problem here. Yersinia enterocolitis, very few people diagnosed here. Carcinoid syndrome, we introduced the first test of chromogranin in this country. Brain demyelination with biologics, our first cases. Xanthelasma, GIT, and GIST. This is actually our award from the American Society for all these what we have done here. And this is actually Iraq, in the small textbook of medicine that was many thousand years ago. Now here in our area, of course, artificial intelligence coming, but hepatitis C came out, but we have new hepatitis B. Less infection, but more inflammatory bowel disease. High living standard, but obesity and coming diabetes and cancers. Genetic diseases with the close marriages in the area. We have more robotics in medicine and welfare, but cannot do open surgery. Some people trained on robotics, but they cannot open the abdomen. More endoscopic natural orifice, endoscopic bariatric surgery. We need a lot of training. We need to invest in science. Artificial intelligence in gastroenterology is coming with polyp detection, video capsules, management of plants and HCV infections and anticoagulants. Gastroenterology is part of medicine. Having a strong foundation in internal medicine is essential to be an effective doctor. After all, many of the GI conditions and pathologies you will encounter are closely involved with other parts of the body. The liver is intimately connected to others. Gastroenterology is unique that you see medicine plus you use your hand and your instrumentations. What are the gaps in our practice now? Detailed, holistic approach to the patient, and also detailed history taking place. Detailed family history for a clinical examination, including the mouth, the skin, the joints, the abdomen, the chest, and the rectal examination. In 20 years from now, cancer will be the #1 cause of death in this country. Here they start a program for healthcare. I think we need to take this to Iraq, actually. Priorities. See, now they put the first prevention of cardiovascular disease, road safety, tobacco, and then cancer. And 30% of cancers are preventable by very simple measures. And the questions to healthcare workers in all specialties. How many of you examine the teeth of the patient? For dental and mouth, because in celiac disease, you can diagnose from the teeth. How many examine the joint for hypermobility to diagnose superior intercardial syndrome? And recurrent varicocele for urologists. And recurrent varicocele can be superior intercardial syndrome. How many auscultate the abdomen for bruit? How many examine the heart for murmurs? How many examine the reflexes in the body? Avoid the pathologist. We are medical students. We are not treating diseases. We are treating patients. And the emergence of specialist care led to the people focusing entirely on their own specialization and losing sight of the big picture. Disease-specific specialization has led to organize the needs for special separately. Those with complex multiple problems must go through several routes. Actually, these are the missed diseases in our areas: eosinophilic enteropathy, Hirschsprung disease, Whipple disease, non-celiac gluten sensitivity, pseudo-obstruction, in general medicine, primary immune deficiency, myositis, sarcoidosis, and genetic disorders. And I think all these books now we can read in a small chip, by the way. We are part of this system. And working in difficulties, this is now coming to Iraq. 13 years of siege, what we have seen. We established the Iraqi Gastroenterology Society during the siege. We established the Gastroenterology Hospital. We built it, actually. We established the Iraqi Board of Gastroenterology and Surgery. we started model training, model by ourselves. And that time, we used the watermelon for training on the advanced endoscopies. That time, we have no dilate for achalasia. And we were sending condoms for birth control to Iraq. We used the condoms to dilate achalasia because we have no dilators. We use contrast medium for radiology, 7 years expired in Iraq. We use old cameras to make slides for projection for students. And we made old pipes to make, I will show a few slides. We published in that time 6 papers. This is the one, that's our scopes that we're using in Iraq. Clustered scopes. We use the hoses of the old instrument to make, plan to check for colonoscopy, for gastroscopy. And this is actually this one here. So I won't go back. This one here, we have no way to present our slides. So let all cameras bring together a slide projected for the audience to see. Sorry? Is my time over? These are all Iraqi-made things for training, and we succeeded. We toured all the country. We toured all the governorate, north and south. We made diagnosed celiac disease, multiple autoimmune disease, Lynch syndrome, Cowden disease, elasticity, Mediterranean fever, periodic diseases, neck tumors, infection, TB, yersinia.
Sorry, Dr.
here, C. diff, slow rectal ulcer, and eosinophilic enteropathy. For example, Iraqi guy here, engineer.
Sorry for interruption, Doctor. 3 minutes left.
A patient here, engineer. He came here, went back to Iraq, and the way to the airport, he had chest pain, admitted to a big hospital here. Then for the abdomen, he's hypertensive. He interrupted his flight, and he admitted to hospital. The CT scan done, which showed small lesion in the adrenal, but they saw there's emphysema of the stomach. We call it emphysematous gastritis with left adrenal mass. And he was seen by advanced surgical department opinion. He came to Dubai, to Abu Dhabi, and then emphysematous gastritis is rare. I would not read about it, but anyway, what we noticed here that this patient has hypertension. He had alcohol the night before. He has a lump in the back, nobody noticed, removed before many years. CT scan in Dubai showed gastric emphysema with left adrenal mass. He has headache and dizziness with nystagmus. And examining the skin is this. In the back, there's a scar. And this is kapha olea. What's your diagnosis? CT scan next day. CT scan, that's it. Glioma of the brain, cancer of the brain. Surgery, he has hemiplegia. That was missed completely. This is one example of the thing how young guy, skin lesions, Cowden disease, rare disease, with multiple surgeries, missed by 7 hospitals. And I think this is another one, dry hand, dry feet. Tylosis carry 80% risk of cancer. And this is actually I want to very quickly show a few other things. Vascular compression syndromes that we see. We have seen about more than 20 cases, all missed like this. Check your patient for this elasticity, please. And this is associated with elasticity syndromes like this. Check your patient, examine well, please. And actually, cancer, we see cancer 15 years younger than the West. And this, we don't want to see cancer like this. You can detect it. In cancer, your genes you cannot change, but you can change your lifestyle. I have only 30 seconds. 1 minute, خلاص. I think I'll stop here. Check yourself, all of you, above 40. Your risk of cancer 5%. الله يحفظكم انتم وعوائلكم، يحفظ بلدنا العراق والامارات. شكرا جزيلا.
Invite Dr. Ibtihal Fadil for the second presentation. Dr. Ibtihal, she's Assistant Professor of Community Health in Iraq, public health physician. She's a founder and chair of Eastern Mediterranean Non-Communicable Disease Alliance, chair of MENA Coalition for HPV Elimination, former regional advisor NCDS, WHO. She is working at Eastern Mediterranean NCD Alliance. So Dr. Ibtihal is going to talk about the achievement of the Eastern Mediterranean NCD Alliance. So let all welcome Dr. Ibtihal, please.
NCD Alliance is like التحالف العالمي للأمراض غير السارية. It's a group of the main, I think most of you as a clinician, you work in this area, you know Civil Society for Cancer is the UICC, is the biggest organization working in cancer. And for the heart, Cardiologist World Heart Federation, for diabetes, International Diabetes Federation, and for lung disease, the International Union Against Tobacco and Lung Disease. All these four big organizations form one coalition because they are working in the same area. They form one coalition called NCD Alliance. And we are working as a member or representing the region, the Eastern Mediterranean, with NCD Alliance. So this union is formed up basically before 2011, where they decided that non-communicable disease is the main killer. These four diseases is the main killer, and they will continue for years as the main killer. So let's work together as one alliance. And basically the mission is to combat the NCD epidemic. So we are facing a strong epidemic of NCD. Similarly, in our region, when we talk about, all of you know, the four common disease, cancer, diabetes, they are the killings. Over 65% of death in the region. When I say Eastern Mediterranean, because I work in WHO, and we have a 22 country head, we call it the Eastern Mediterranean region, extend from Morocco up to Pakistan. And if you talk about the four diseases, like they are causing over 66 of the death in the region, and they are also the causes of a premature mortality. So most of the people who die before 70, they are dying from cardiovascular, diabetes, and so on. Cancer, as Dr. Makki said, 16% of the death from cancer, and there is a lot of increasing cancer in the region. We have, unfortunately, the risk factor for this disease, اللي هي tobacco, physical inactivity, bad nutrition, so all these are increasing. We are expecting to have more of the chronic disease in the future. In our region, we have more than half of the country, including Iraq, are suffering from emergency and political instability. And this also, you know, impacted heavily on the health system and impacted heavily on the treatment of chronic disease. What about us? What we do? So we are formed as NCD Alliance. We are formed in 2017, and as I mentioned, it is the group of society who work in these diseases. We have currently over 45 society working with us, including many of the society in Iraq, the thoracic, cardiothoracic, the hypertension, the cancer, all these society in Iraq, they are working with us. I give you some, in this slide, I provide some example of the society we are, but if you go to our website, you find we have more than 45 society which are responsible currently for cancer, cardiovascular, and diabetes, and so on. Why we talk about civil society or NGO works? Because a non-communicable disease, a chronic disease, is not a clinical only. There is a lot of element which is non-clinical, and it's mainly related to lifestyle. So if we want to combat these diseases and prevent them, we have to work on a multi-sectoral, and we have to work on a multi-policy, and mainly is related to what we eat, what we do, and what's the environment we are living in. And this is why in 2011, the UN Political Declaration for the first time, do you believe it? For the first time in life, a subject related to health are discussed on the UN Assembly. And that was for a chronic disease because of its impact and effect. So they discussed this one, 2011, and they come with what we call it a health in all policy. What we mean health in all policy, that Ministry of Education have to consider health. Ministry of Environment have to consider health. Every sector every ministry have to consider health. So this is the work, what we call it, in partnership. And this is why we build this NCD Alliance, to work with different sectors, not only Ministry of Health. So like currently we are working with all this agency. This is the inter-agency work. We work with government, we work with civil society, with different ministry as well as with UN. We work closely with the WHO, with UNDP, and all other UN agencies responsible for area of even not health, even agriculture or different area. My work as a civil society, network of civil society, we focus on 3 areas. We do advocacy, we do accountability, and action related to non-communicable disease. So in terms of advocacy, we do a lot. Like today, I am advocating with you about the importance of non-communicable disease. So we attend different platform events, all the regional events and all the global events to advocate for the importance of non-communicable disease. What I mean watchdog, like we produce a report to make government accountable for their action. Like if there is a taxes on, say, tobacco, taxes on sugar, sweetened drinks, we make a government accountable for this action. And also we do capacity building. We have many courses and many training in our region, training of doctors, training of patients themselves, and training of different sectors. So this is a sample of what we do. Examples, we attend WHO meeting, World Health Assembly, and produce also a report and produce what we call it a policy brief. So this is like a policy advocacy document we produce on introducing taxes for tobacco, alcohol, taxes of sugary drinks, and also increasing physical activity. Think peace. So we work with WHO also to advocate with the government to increase action and prevention related to non-communicable disease. Raise awareness. The civil society work with the community also, like in Cancer Day, in World Health Diabetes Day, in World Heart Day. We produce all these documents to increase awareness about non-communicable disease and focusing on prevention and healthy lifestyle. We produce a civil society report, that is the status report. I talked about training also. So this is the major activity we do. There is a lot of things going in non-communicable disease. Partnership is important. So we partner with different sectors to improve the work. In general, the fight for non-communicable disease is a challenge, and this is the diseases for the future, and it is a long-term fight. We need a collaboration with all sectors beyond health, and the collaboration is mainly focused on reducing risk factor, and we are aiming of reduce premature mortality. Like Dr. Mekki mentioned about colon cancer early diagnosis. So we focus on the early diagnosis of all cancer, similarly early diagnosis of cardiovascular disease, and other area which is related to improving the health of the population and the well-being. Thank you for listening. There is a lot to see, and also I'm ready to communicate with you for future work. We are on the website for more detail. Thank you very much.
جمعية الإمارات للأمراض الجينية for giving us this opportunity to get us together, and we share our recent advances in medicine, and also it's the This is a very nice social event. We can see our friend and colleague from all over the world. So it's really a great opportunity. I would like also to thank Dr. Mariam Matar for organizing this and paying a lot of effort to get us together. So on your behalf, I would like to thank Dr. Mariam Matar. And today I would like to address you with the recent technique and medicine and also operations we perform in ophthalmology, in the eye healthcare. The first thing to focus about Rabaya. Rabaya is a new treatment to a dry eye. We all use lubricant eye drops to lubricate the eye and to get rid of all complication of dry eye, which affect the cornea and affect the vision and interfere with the integrity of vision. So we are living in a country, GCC, where we have a lot of hot weather and sunshine, and we almost use lubricant or eye drops for most of our patients to avoid complication of dryness. This is a new things which you give the patient as a nasal spray, and this will stimulate the parasympathetic supply of the eye and lead to wet eye and treat all the causes of dryness and complication, because dry eye is not only symptoms or a single disease, it's a complex of diseases. It could affect the lid, cornea, and the conjunctiva, and lead to a chronic scarring of the cornea. So it's very important to bring something new to treat that efficiently, and this is what we are treating now by nasal spray, stimulating the parasympathetic supply of the lacrimal gland and causing excessive secretion of tears, leading to wet eyes. Duresta, this is another new things in eye healthcare, and we know all about glaucoma. Glaucoma is a condition which leads to silent blindness. And people suffer from glaucoma means they will have higher intraocular pressure than normal. So if you have intraocular pressure more than 20 millimeter of mercury, most likely you have glaucoma. And glaucoma is a silent disease. You will never experience any pain or any discomfort, especially when it is chronic, not in acute stage. And the traditional treatment is to put drops in the eye. Sometimes you put it 2 times, 3 times. Sometimes you take tablet like acetazolamide or Diamox, and this has got also a lot of side effect. So this new technique now is to inject a capsule in the anterior chamber, and this capsule will let the intraocular pressure down to normal for almost 1 year. So the patient does not need to have very frequent and bother about the drops every day, like twice a day and so on. So to avoid this blinding disease, glaucoma, is now we have a new medicine to be injected into the anterior chamber once a year. The other new technology, you are aware of a condition called keratoconus. Sometimes the cornea is very thin, or it has got some degenerative disease, especially after very frequent rubbing or chronic vernal conjunctivitis or allergy. The cornea will become very thin, and then it will become steep cornea, and the patient will lose his vision or good vision, and it will not be corrected by glasses or by conventional surgery like LASIK or femtolasic or other modality, PRK or SMILE, because the cornea is very thin. So this condition can be treated on the slit lamp in the eye clinic by doing what we call corneal cross-linking. We put the patient on the slit lamp, and then we subject him to ultraviolet light, and every couple of minutes we install vitamin B2, or what we call riboflavin, on the cornea, and this will last for about 20 minutes. And this will make the cornea back to normal. And he does not need to wear glasses or to be subjected to the other surgical technique. So cross-linking can be done as an outpatient. This is a new technology as well. Resight. Now, as you know, most of us after the age of 60 will be suffering from what we call cataract. Cataract is a lens opacity which happened to all of us one time in our life, and this is a normal evolutional changes which lead to blurred vision due to cataract. Cataract means lens opacity. So the conventional treatment is to remove the cataract and replace by intraocular lens. And the conventional one, the usual one, is monofocal or multifocal, IOL or intraocular lens. And this procedure could be done under topical anesthesia as a day case. So patient come in and have his cataract removed or her cataract removed and then replaced by intraocular lens. Now the new technology is to change the intraocular lens to a different power, because sometimes we make the calculation and it's not always become very accurate. So we put the power, like say plus 20, and then we will discover that the patient in need to plus 21 or plus 19. So the patient will not have accurate visual acuity like 20/20 because of the improper calculation or some changes in the movement of the lens forward or backward. This is another new laser which is also used in the outpatient or in the theater. It's called capsular laser. Now when we remove the lens, we usually go to the lens by removing the anterior capsule. As you all know, the anatomy of the lens, it has got anterior capsule, then the nucleus with the cortex, and then posterior capsule. So when we remove the cataract, we preserve the posterior capsule in order to avoid any forward movement of the vitreous leading to retinal detachment. So always we cut the anterior capsule in a circular way, but we do it now manually. So we hold the capsule by forceps and try to do capsulorhexis or opening the anterior capsule in a circular manner. Sometimes we are exposed to some complication. This manual procedure, it might extend and lead to tear in the anterior capsule, which might extend to the posterior capsule, and then we will face complication of vitreous loss, high pressure, retinal detachment, and so on. So the new technology is to use this laser, or called laser capsule. You will have very meticulous and accurate capsulorhexis, as you can see in this slide. And this you can do it also under topical anesthesia. Then you can proceed with the surgery. It will be most likely complications-free. This is a new medicine also, Tebeza, which is an IV injection. We give it to the patient who have some dysthyroid problem like hyperthyroidism, and then they will have what we call proptosis or exophthalmos. And this is very annoying complication of dysthyroid disease. And sometimes, you know, it will cause severe dryness. The eye cannot be closed. Patient will also looks not normal by having bilateral or unilateral exophthalmos. And the old technique is either we do it, treat it conservatively by steroid or surgically by what we call orbital decompression, which is a major surgery. Now the new treatment is to just put IV Tebeza, and this will not cause exophthalmos or proptosis. Now we have also a couple of services, which is new, where we also practicing in our center in Bahrain. Now, sometimes we do what we call cosmetic coloring of the eye. Now, if you have an eye, like what you can see on the left side, now this is really does not look normal color and cause some embarrassment to the patient. Now we can put cosmetic contact lens inside the eye, not outside, inside the eye, and this will be a permanent changing the color of the iris or eventually of the eye, so it will be identical to the other eye. So this is the patient, pre-operative and post-operative. And this is what we do in our practice in Bahrain. This is just a picture of Bahrain. Small island, small country, but very hospitable and beloved by most of the GCC country. This is a procedure. This is my daughter, and I do a combined surgery, which is called DCR, or dacrocystorhinostomy. We have a good number of patients where they suffer from what we call epiphora due to closure of the nasolacrimal system or channel. And we usually treat them first by what we call syringing and probing, but a lot of cases we might not succeed to open the channel, then we have to do surgery. And this surgery, the old one, is done through an incision on the face, below the eye and on the nose. Now the new technique, we are doing it in Bahrain, we call it endoscopic DCR. So we do it through the nose. There is no incision whatsoever. It's an outpatient procedure also, or one-day case surgery where you open a new channel through the nose and then put a tube, Vodkin tube, from the eye to the nose. This tube, plastic tube or silicone tube, will stay between 3 to 6 months. Now this is a very nice case. We call it life-changing case. A young lady, she's only 20 years old, from Saudi Arabia, and she approached us because she wanted to get rid of her glasses. Her glasses were tremendously thick, and she was wearing like a plus 18. Plus 18 mean very thick glasses. For a young lady, it caused a lot of embarrassment. So what we did here, if we want to replace the lens and put a new lens, the maximum power of the lens is plus 30. So there is no lens manufactured by all the lenses company more than plus 30. The usual lens for normal people is 20, 22, like that. This lady, this young lady, her calculation was 56, plus 56. So to get rid of her glasses, there is no way to do it by laser or LASIK or SMILE because she has very high power. And the only way to do it is to replace the lens by new lens. So what we did, we put two lenses. One lens is plus 30 and the other lens plus 28. So this is what's called piggyback. Piggyback means two lenses, put it one in the bag of the lens and one in the sulcus. And then the patient will get rid of glasses, and it was like life-changing case. Thank you. Thank you very much. I hope I just address you with some new technique in the eye healthcare, and that's what we are practicing in Bahrain. Thank you.
Dr. Ali, working in Dubai Health in particular at Al Jalila Children's Hospital in Dubai, and for his presentation, he will talk about the genomic landscape of pediatric gastroenterological disorders in the Middle East, clinical implications and advancement. Just to remind and to confirm that we have, Dr. Ali, you have 15 minutes for your presentation, and then after that we'll have another important talk. Then hope we'll have another time for your questions. So please, let all welcome Dr. Ali, please.
Assalamu alaikum and good morning, everyone. It's a pleasure to be here today, and thanks for the organizing committee for organizing this nice gathering and conference. Without further ado, I will present to you. So I have no disclosure for today. The main objectives for this presentation is mainly to give you some clues about genetic testing, specifically in pediatric gastroenterology field, and how this can impact the management plan. We know always about genetics. There's always a question about, do we do these genetics only to know the diagnosis, to know the name, know the physiology, then how this will impact our management, how this will change our approach to the patient. So this will be our aim and the main goal of this presentation. And I'm going to show you real-time data. You know that genetics has been advancing the last couple of decades, years, and specifically last 10 years. And we know so far 7,400 genes, 7,400 diseases, and we know the genotype for these diseases. And while I'm speaking to you right now, this number is increasing. It's changing. There's a lot of publication. We are knowing more and more about these genetic and molecular bases for these diseases. We used to look at the disease and try to find the genotype, but now I think it's changing. We are looking at the genotype and we are trying to fit it into a phenotype. We find the genetic mutation or the alteration even before finding and seeing the disease. And we know that in the future they are very liable, or probably they will develop the disease. So it is actually it's a game changer. The importance of this topic is specifically in our region, the Arab population, is because of the consanguinity. We know that in some studies and some reports, we have up to 20, up to 50% consanguinity in some countries. And in general, literature does not represent our population very well. So I think this is an important topic for us in the moment and also for the future for further research. I will try, because the time is very limited, I will try to go to the money directly. We know, as I mentioned, historically, and what we used to do, that genomics are mainly to find some answers about things, how things happen, pathophysiology or some basis, but how it impacts, we don't know much about it. In some studies, they have mentioned and they have found some genetic mutation for cholestatic disease and how these mutations could cause the cholestasis, how could this mutation could damage the liver, but it did not impact much on the management. Also in IBD patients, we know in pediatrics, there are those who are less than 6 years old, a very early onset IBD, they're always, most of them, I wouldn't say always, but many of them, they have monogenic mutation causing them the IBD. And the whole story will change, and I will show you how is that. Also, there are some studies talking about functional gastrointestinal disorders, such as IBS. We know IBS is, some bloating, some gases, but they found there are some genetic makeup for this and interacting with the environmental factors. This is what we know so far. Here I'm going to present to you a cohort of patients, specifically pediatric in gastroenterology field, and they had the genetic testing done for them. There are around 74 patients. The data is between 2019 and 2023, and we have done different genetic testing, including WES, chromosomal microarray, and targeted genetic analysis. And we have grouped them into 6 different groups in order to understand them. The results showed that we had a variety of cases, and also the spectrum of the severity of cases, and also the ages. So it ranges from 2 weeks up to 18 years. And we're talking about an average of 3 years of age. Majority of them were males, about 64%. And the interesting about this study is that we have 72% Arab population. So here we are representing the underrepresented population, and 50% of this population, or this cohort, is Emiratis. The biggest group was the liver disease. They had around half of the cohort, then followed by the chronic diarrhea, and then we have a smaller group of IBD, pancreatitis, and polyposis syndrome. Genetic testing for these patients, half of them, they had positive gene mutations. So we identified alteration in the genetic makeup for these patients in up to 52%. The highest group, or the highest yield, was in the chronic diarrhea patients. Up to 76% of them, they had the mutation. And interestingly, we had 10% of the genetic mutation were unexpected. So we were testing for a specific disease, we were looking for a specific answer, then we get a completely different mutation that has nothing to do with this patient. And it had a lot of implication for the time being and also for the future. This is just a glance and a small sample of the genes that we have detected in our patients, and you can see the list it's very lengthy, a lot of letters and numbers. And we know autosomal recessive is the commonest, and this also presented in our cohort. We had around 49 patients with autosomal recessive mutations. The main question was how this genetic mutation or this genetic testing would alter my management, how it will change to my approach to the patient. And in this study, we found around 89%. So 9 out of 10 times when we detect this genetic mutation, we could change the management based on the genetic testing. So without the genetic testing, we would have done something different. And here I will give you some examples. So for example, liver disease. Testing some patients with Gilbert versus cerebral Najjar is completely a different story. Only by detecting the Gilbert disease, we can reassure the patient we will stop testing this patient anymore, and we know the benign nature of this disease. While diagnosing cerebral Najjar patients, we know this disease is progressive, and these patients might end up with liver failure. So based on the genetic testing, we have suggested to go for liver transplant or phototherapy, or sit calm and just forget about the disease. One more example is PFEC. It's a very rare condition. It's called progressive familiar intrahepatic cholestasis. And based on the genetic mutation, we change the management completely. For example, type 1, in PFEC type 1, we know very well that this is a systemic disease. So even with the liver transplant, we don't advocate for liver transplant because they have a systemic disease. They have intestinal involvement and they have others. So we don't do that. In type 2, once we know this PFEC type 2, based on the genetic mutation, and whenever we have a truncating mutation, we know that this patient should go for liver transplant even before having liver failure. So we would do it before even liver transplantation because we know these patients, they have high risk of malignancy, so we don't wait. For example, mitochondrial DNA diseases, when they have liver involvement and they have other systemic involvement, again, we don't transplant them because we know the prognosis is very poor, and we will know this only when we have the genetic mutation. For IBD patients, usually very early onset IBD patients, they have the genetic possibility, they have a genetic mutation, but not all of them. And our also cohort showed something similar to the published literature. Around 70 to 80% of them, they didn't have a mutation. But when we have the mutation, it was so important to know. Why? Because when you have Crohn's disease or ulcerative colitis, you treat them in a different conventional way, use biologics, you use azathioprine, use other medication that has to do with the immune system. But when you find a patient, pediatric patient, and you diagnose them with CGD, which is an immunological disease, and they have the IBD, you don't treat the IBD anymore. You transfer them directly to the bone marrow transplant, because whatever you do for the IBD, they will not respond. So from the genetic mutation, you decide from the beginning, you send them to bone marrow transplant in order for them to recover. One more example is when you are treating these IBD patients with azathioprine. It's a well-known medication, immune modulator, and you have to check a specific enzyme to make sure that this drug will not cause you troubles. And we are now currently using the TPMT gene, or the genotype, in order to know if this disease is going to, this drug is going to trouble us or cause us side effects or not. We don't depend much on the enzyme level anymore. We look at the genetic. Especially these patients, they have always anemia. They get blood transfusion, so the enzyme is non-reliable anymore. So you depend on the genetic to decide if this medication is safe or what dose also you're going to start. And there are even more and more implications. For pancreatitis, they helped us mainly when we identify genetic mutation to understand the process in which this patient is getting the pancreatitis. But also they helped us to refer some of them for annual screening because some of these gene mutations, such as PRES1, is high likely they will develop cancer. So you need to screen them annually in order to prevent this disease. And also we found in some patients, they are carriers for TOLP3 and MYBC3, and both of them, they were associated with cardiomyopathy. So that was a high alert signal that came to us, and we had to refer the patient immediately to the cardiologist based on the genetic mutation, just to have a screening echo, because they might have cardiomyopathy and they might have sudden death in the future. So based on this genetic testing, we could somehow maybe help them or prevent this issue. another group is the chronic congenital diarrhea, and the chronic congenital diarrhea, it's so difficult to diagnose these patients only based on the microscopic or electronic microscope or from the labs. They look the same, they pass a lot of stool, they are congenital, so difficult. But once you use the genetic testing, you can identify which type of these mutations are there, which type of congenital diarrhea, and it affects also your decision on what's next. For example, if you have MYO5B, you know it's microvillus inclusion disease and you need TPN forever. But if you have, for example, a tufting enteropathy, that's different. You don't transplant, you don't offer them intestine transplant because you know with time they will improve and their autonomy of the enterocytes will recover. So it changes your management in this situation. Also, other rare situation or rare disorders called trichohepatoenteric syndrome, and we had 2 patients, and these patients initially presented with congenital diarrhea, but they have high risk of liver disease. So we continued screening them, and they developed cholestasis later on. And also the trichohepato neurodevelopmental disorder, also they have neurological problems. So also we have to keep screening them for neurodevelopmental disorders. All of that is just based on the genetic testing and the mutation. Failure to thrive, it was one of the groups that unfortunately genetic testing did not help much. We have 50% of them, they had genetic mutation, but unfortunately this genetic mutation was not able to identify the reason for the failure to thrive. Yet it showed us and it gave us some mutation that helped us to look for different diseases, such as CFTR gene looking for cystic fibrosis, or the CARMEL2.
Dr. Ali, 3 minutes left.
Okay.
3 minutes left.
Thank you. Which is associated with immune deficiency, so we had to screen them. So we screened them and we diagnosed them to have immune deficiency before the manifestation of the disease, just based on the genetic testing. And we have a very small, only 2 patients with polyposis syndrome, post-Ziegler syndrome. They had the typical standard gene mutation that's called STK11. Both of them, based on the genetic mutation, when we know that this is the diagnosis, we refer them for an annual screening. And also, we have tested their relatives because this is an autosomal recessive disease, and once you diagnose one patient genetically with this mutation, you have to screen other patients, relatives. There is high likely they will have and carry the same mutation. What is about the future? The future is here already. There is the little falcon you can see. This is a study that we are already running now in Al Jalila Children's Hospital. This little falcon is looking at the West whole exome sequencing that is usually taking 2 months to 3 months to get the results. But we are doing it in 2 days, and we are looking at how this can affect the prognosis, the management of the patient, shortening the stay in the ICU, shortening the time to get answers, changing the management from second day instead of waiting for 2 months until you change your management. And it's giving us great results, and this might be proposed in the future, and the West might be getting shorter and shorter, and you might be getting your results within a few days instead of a few months. And the other one is the whole genome sequencing, and we are also moving from the whole exome sequencing to the whole genome sequencing. With the new advances and new technology, we are being more able to analyze and study the whole genome, and getting more important mutations and identify novel mutations as well that were not discovered with the whole exome sequencing. So in conclusion, I think genetics used to be something scientific. Now it's in a practice, and I believe personally it is a game changer. And from lab tests, I think in the future it will be a small prick bedside, you get the results, and it changed the entire management plan within a few minutes, if not a few hours. These are my references, and thank you so much.
دولة الإمارات العربية المتحدة، دولة التعايش والتسامح، ومن إمارة المستقبل دبي الفتية، وبرعاية معالي الشيخ نهيان بن مبارك آل نهيان وزير التسامح والتعايش والرئيس الأعلى لجمعية الإمارات للأمراض الجينية، بدعم من هيئة دبي للاقتصاد والسياحة ومؤسسة الإمارات للخدمات الصحية التابعة لوزارة الصحة، وفريق شكراً لعطائك والراعي البلاتيني فارمالاب وAMS. تستضيف دبي جائزة باو والمؤتمر الطبي العراقي في اليومين 24 و25 من شهر كانون الثاني يناير عام 2025، والذي يعقد في مكتبة الشيخ محمد بن راشد آل مكتوم، تماشياً مع توجيهات القيادة الرشيدة لاحتضان العلماء والمتميزين من بلاد العالم، والتي تعكس الرؤية التي أرساها المغفور له الشيخ زايد بن سلطان آل نهيان طيب الله ثراه للاحتفاء وتكريم الكفاءات العربية التي ساهمت في خدمة الإنسانية. خصصت الجائزة في دوراتها الأولى لتكريم أبناء الرافدين من الكفاءات والمبدعين من حول العالم. من المكرمين في هذه الدورة الدكتور علي الحرجان استشاري الطب النفسي الذي أرسى النسخة الأولى من هذا التجمع العلمي، وسيتم تخصيص كل دورة من الجائزة للاحتفاء بالكفاءات من دول عربية مختلفة.
Ladies and gentlemen, I'm truly honored to present the esteemed chairperson of the Iraqi Medical Conference for this year, and she is the head of Emirate Genetic Disease Society, Dr. Maryam Matar. Dr. Maryam has been one of the major contributors to the success of this event. She has been incredibly generous with her time, efforts, and resources, ensuring that the conference is a truly remarkable and successful story. Ladies and gentlemen, join me to welcome her to the stage.
حياكم الله في داركم دار الشيخ زايد بن سلطان آل نهيان، وهلا ومية هلا مثل ما يقولون، فهلا وربعنا. انتم اهل الدار واحنا ضيوف، وسامحونا على اي قصور بدأنا في بداية التسجيل. ان شاء الله كلنا نتطلع ان يكون يومين يعني ان شاء الله في تلاقي للارواح والعقول ان شاء الله. انا ما بقدر اتكلم كثير عن المؤتمر. دكتور مناف عربي ولا انجلش؟ عربي؟ عربي بس العراقيين ما شاء الله، العراقيين انتم ما شاء الله وايد شايفين نفسكم تستاهلون ترى. أول شيء بداية اليوم المؤتمر هذا حصيلة جهد فريق عمل اجتهد من كل قلبه، وطبعا نبدأ برئيس المجلس العلمي دكتور يحيى الكيوان. شكرا جزيلا دكتور. لما نتكلم عن المجلس العلمي ما نقدر ننسى زملائنا في المجلس العلمي جزاهم الله خير، كلهم اجتهدوا وسووا الكثير. وسامحوني يعني باجي اراء المجلس العلمي اني اخص دكتور مناف بالشكر الجزيل على كثير من التمييز والعطاء. مرات انا ودكتور يحيى ودكتور مناف كنا نجلس لين الساعه 1 الفجر بس عشان نقدر نعدل البرنامج ونحاول نغطي الكل. واليوم المؤتمر ما كان بينجح لولا وجود اساتذتنا الكرام اللي اعطونا من وقتهم من جهدهم انهم يجون اليوم ويشاركونا العلم اللي الله اعطاهم اياه. فبالتالي اليوم المؤتمر متوج بالمحاضرين والسبيكر لهذا المؤتمر. وطبعا ما ننسى دكتور عماد. دكتور عماد شكرا جزيلا. دكتور عماد رئيس الامانه العامه لجائزه باو. جائزه باو يعني طلعناها من التاريخ، هي آلهة الشفاء عند السومريين، واحنا في دوله الامارات العربيه المتحده تبنينا هاي الآلهة وقمنا باستحداث هذه الجائزه اللي نكرم فيها أهلنا وربعنا من بلاد الرافدين اللي تميزوا في الجانب الصحي في العالم بالعموم، ونكرمهم في دولة الإمارات. في الأمانة العامة بتشوفون في الويب سايت وكذلك في البوكلت اللي موجود عندنا كثير من الإخوان اللي لهم باع كبير وحتى حضور في الجانب الاجتماعي. وخاصة من النطاق الصحي. أنا سمعت كثير ما شاء الله استفسارات ليش دكتور نصير شنة موجود في مؤتمر طبي؟ ليش فلان موجود في مؤتمر طبي؟ احنا في دولة الإمارات العربية المتحدة بتوجيهات الحمد لله المغفور للشيخ زايد رحمة الله عليه والخلف الطيب من وراه، نضمن أن يكون في تكاملية في خدمة المجتمع. ما نخلي فقط الجانب الطبي لوحده، ونضمن أن لما يكون في جانب طبي مو فقط أطباء، لازم الطبيب، الصيدلي، زميلنا في طب الأسنان، الممرضين، كلهم نكاتفهم مع بعض ويكونون موجودين في هذا المحفل أو غيره من المحافل. فبالتالي وجود دكتور نصير شنة إضافة كبيرة جدا جدا للجائزة، وخاصة مشواره الطويل في خدمة المجتمع من خلال توفير الخدمات الصحية خاصة للأطفال المصابين واللي تم تشخيصهم بأنواع معينة من السرطان. وطبعا لما نتكلم عن الجانب الاجتماعي، من الناس المكرمين السنة واحدة من شركات الأدوية في العراق، إن شاء الله بيشوفون باسم باكر. هذه الشركة بغض النظر عن بعدها عن دولة الإمارات، ولكن عرفنا ودققنا وتأكدنا أنهم يخدمون المجتمع العراقي من خلال تقديم العلاج الطبي للسرطان بدون مقابل أو بمبالغ رمزية جدا. ومن هنا كانت جائزة باو الاحتفاء بأهل العلم والعلماء والأطباء، وكذلك الاحتفاء بالناس والجهات الأخرى اللي موجودين في شبكة الحماية للمجتمع اللي يوفرون هذه الخدمات. سامحوني إذا طولت عليكم بالكلام، ولكن تشوفون المؤتمر اليوم يمكن فقط محاضرات علمية، وجود زملائنا يحاضرون، بس هذا المؤتمر يعتبر من وجهة نظري خيمة لمتنا احنا كلنا مع بعض، وضمنت ان امتداد بلاد الرافدين من دجلة والفرات مو بحدودها فقط ارض العراق، ولكن امتدت للامارات. ونقول لكم مرة ثانية هلا و100 هلا مثل ما يقولون اهلنا في العراق. حياكم الله ونتمنى لكم يوم سعيد ان شاء الله، وباكر ان شاء الله ان الغالة دينر. اتمنى لو سمحتوا من جميع الحضور واللي يسمعونا واللي بيوم باكر، الشيخ الهيان ان شاء الله طيارته بتحل الساعة 9:30، ونتمنى الحضور يكون موجود قبل، فبالتالي اذا تكونوا موجودين الساعة 9 بتساعدونا في التنظيم، ونضمن ان شاء الله الامور تكون سلسة. انا صراحة ما بقدر اني اختم بدون ما اذكر اختي الغالية دكتورة وسن، تفضلي فديتك.
Now the time to certificate with the speaker, and we'll take about 15 minutes break or half a break and for the second session. Thank you very much for your attendance.
So we would like to present our speaker presenters, Professor Mehdi Fayyad, Dr. Abdihad Balal, Dr. Muhammad Arifi, and Dr. Ali Hassan, with certificate of appreciation and a show of gratitude for their valuable time and welcome home to the